We are in part 2. We're going to talk about the rest of the 5R. We're starting with replace. So what does Joan need in terms of replacement? We need to determine the need for digestive support. So what else can we learn from Joan's stool analysis? Well, we find that her pancreatic elastase 1 is low. Now, pancreatic elastase is a human enzyme, so it is an excellent marker for exocrine pancreatic function. And hers is low. So what does that mean? Well, it could mean that she has exocrine pancreatic failure, but that's not common. What's much more common is that she has an abnormality in the cholecystokinin feedback loop. And that usually means that there's some kind of injury to the brush border. So not only does this test tell us that she does not have adequate exocrine pancreatic function, it alerts us to the more than likely idea that she has brush border injury. So there is some name confusion. If you look at the clinical literature, it will be called pancreatic elastase 1 or human pancreatic elastase 1. But if you look at the more fundamental literature, the scientific literature, you may see it called chymotrypsin-like elastase family member 3. It's exclusively a human enzyme. So it is, number one, you won't alter it by giving exogenous enzymes. It's not digested during transit, and it gives information about this exocrine pancreatic function. It also gives us information about the CCK signaling pathway, and it relates to brush border health, as I said. So just to remind you about this CCK pathway, CCK is secreted in the small intestine and stimulates the higher organs of the alimentary system to do what needs to be done, whether it's releasing bile or releasing enzymes, etc. And here are some references to the CCK ideas. So what can cause maldigestion? This first one needs to be carefully pronounced, but chewing. You need to adequately chew. Unfortunately, most people do not. Most people are like snakes. They swallow it whole. And then hypochlorhydria, especially with stress and with age, our acid production goes down. Pancreatic insufficiency. Now, for various reasons. The most common reason is an injury to the brush border and poor cholecystokinin feedback, not pancreatic insufficiency. But then brush border injury, where frankly, more enzymes are present in the brush border than are injected into the duodenum from the pancreas. Think about the duodenum as kind of priming the engine, but the real fuel of digestion is the brush border. And then bile insufficiency. So there's lots of places that digestion can go wrong. And how can you tell the difference between hypochlorhydria and pancreatic enzyme insufficiency? And the answer to that, in my opinion, really lies in the timing, because acid is in the stomach. That is, right after swallowing, it falls into the stomach, and that's where the acid is. So hypochlorhydria causes almost immediate bloating and belching, whereas indigestion from pancreatic insufficiency, because it actually has to get into the small intestine through the pylorus. So food is held in the stomach by the pylorus for some time, then it's released into the small intestine through the duodenum, and that takes time. So indigestion and bloating and flatulence occurs 2 to 4 hours after ingestion of foods with pancreatic insufficiency. So how can you clinically assess this? Well, signs and symptoms and the timing we just talked about. In the case of hypochlorhydria, there's a betaine hydrochloride challenge test, Alka-Seltzer challenge test, or if you want to get really fancy, there is a telemetry capsule called a Heidelberg capsule that you can swallow, and it measures your pH as it travels through. Pancreatic insufficiency, the best test is really the elastase test. And malabsorption, of course, means incomplete processing of your food. So it occurs because of insufficient acid. The acid starts the process of breaking down proteins, but it also sterilizes the chyme. And then insufficient intestinal brush border enzymes, and that results in decreased CCK stimulation of the pancreas. That results in insufficient pancreatic enzymes and insufficient bile acids. And remember, bile acids are essentially soap helping to saponify and break apart fats so that they can then be acted upon by lipases. So support for gastric acidity. Well, betaine hydrochloride is a B vitamin family, and it has been shown to improve acidity and protein breakdown. Japanese plums help with digestion. So does digestive enzymes, particularly digestive enzymes with a broad pH range. Remember that proteins are broken down by acid, but if you have an acid stable protein, and it turns out that this is sort of code for, they call them plant-based, in quotations, plant-based enzymes, but they're actually fungal-derived enzymes. Usually Swedish bitters help us with digestion, ginseng root vinegar as an acidifying agent, and then vagal tone. If you are eating in your car, if you are eating under stress, if you're eating at that lunch meeting where you're having a contentious issue, you're in fight or flight. You're not going to digest as well. You want to be in a space of rest and digest, of being in autonomic balance in order to digest. And here is a handout in your toolkit about testing stomach acid and what kinds of things can help with digestive support. Well, we've talked about HCl insufficiency. Let's talk about insufficient brush border enzymes. And so what can we do about that? We can use pancreatin, pancreatic enzymes. And this is typically a mixture of lipases, proteases, and amylases, usually a porcine or bovine derivation. And you take them, right at the start of the meal because you want the enzymes to kind of be mixed with the food as it's moving through your system. You can also use bromelain, another enzyme, or many of these, in quotations, plant-based enzymes can be helpful. Well, what about insufficient bile? Well, you can use dandelion root. So these things called cholagogues or choleretics, these are agents that help with the flow or production of bile. So dandelion can be helpful. Bile acid is a more direct approach, just give bile straight away. Or taurine is helpful in the manufacture of bile. So replace. What do we need to replace? So remember, we're thinking about these digestive factors and so on. And in her case, she's got a low pancreatic elastase 1. So at least until we can fix the brush border, she needs pancreatic enzymes. And I would argue until and unless, because for some people, that's difficult. So what's our treatment program look like so far? Well, we've talked about this oligoantigenic diet. We've talked about her blastocystis and getting rid of that. We've talked about her pancreatic enzyme insufficiency. So what do we need to re-inoculate? Or do we even need to re-inoculate? Well, let's take a look at her stool analysis again. And what we find is that she has low butyrate. It's low as a percentage, and it's also low absolutely in terms of milligrams per milliliter. So butyrate is a short chain fatty acids. It's one of the most important fuel sources for enterocytes, and it is made by probiotic bacteria digesting soluble fiber. So what this tells me is that there is a problem with the with the balance of the microbiome. She has dysbiosis, and the cause of that dysbiosis is likely an insufficient amount of soluble I should say, insufficient amount and diversity of soluble fibers. So this really comes down to feeding and seeding, right? And the seeding, a lot of people think about the probiotics as being the seeds, but really it's a matter of if you build it, they will come. If you provide the fertilizer, the proper bacteria will hitchhike in on the food and it will grow. And the probiotics that you provide will be space holders until that happens. So if you have low short chain fatty acids and or low butyrate, you should be considering dietary recommendations to incorporate more pre and probiotics. So what does this mean? This means prebiotic foods. And we'll talk about that in a few minutes, but it's good food. It's onions and garlic and leeks and artichokes and good things that are good to eat, tasty. But it's also fermented foods. So kefir and yogurt and kimchi and all those kinds of things. And then supplements also. And again, we need to be thinking about diversity of probiotics as much as quantity. So as an example, psyllium is almost all soluble fiber, but if you gave just psyllium as a supplement for the prebiotic, that would be kind of a monoculture prebiotic, which would result in more of a monoculture gut microbiome. We want to give a diversity of probiotics. What about, so that's the feeding, and we're trying to rebalance gut flora. So we do that with prebiotics, as we talked about, fermented foods, specific carbohydrates, soluble fibers, synbiotics, which are these mixtures of pre and probiotics, and then probiotics. And the question then becomes what dose, what strain, and what's the safety? So let's talk about diet first. 70% of the foods that in the Western diet are of limited or no benefit to the microbiome. So that means that there is a major opportunity for intervention with diet simply by increasing probiotic foods and fermented foods. And of course, we're talking really about the standard American diet, or the SAD diet, which is high in refined carbohydrates. It's low in fruits and vegetables and so on. So factors including age, genetics, and diet may influence the microbiome composition of these diet. It's hard to influence age. It's hard to influence genetics, although we can certainly influence the epigenetics, but it's much more straightforward to influence diet. So fermented foods, what would that be? Well, it restores and maintains the inner ecology through cultured foods, decreased sugars and carbohydrates. And here's a list of cultured foods, everything from yogurt to miso and tempeh and raw pickles and fermented anything, think sauerkraut or kimchi or sourdough bread, or my favorite, of course, beer and wine. Although be careful with that because the alcohol can actually cause some issues with leaky gut. So it's always a push and a pull. You got to be careful. Consistency of probiotic foods. So there is a lot of diversity in the quantity and quality of, say, yogurts that you find out there. Many yogurts are little more than gelatin with sugar and a little bit of culture in them. So you want to read the label. You want an active live culture yogurt. If you make your own yogurt, and I do this, and ferment it for 24 hours, you're likely to get in the vicinity of 100 billion colony forming units out of that culture. So the problem with that is it's not super sweet. Like when you buy a little thing of yogurt in the grocery store, it's sweet and it tastes like dessert. It's going to be sour, but it's going to be healthier, and it's just an acquired taste. So in your toolkit, there is a list of pre and probiotic foods that you can find. And these are some examples of prebiotics. Everybody always says, health food diets taste like cardboard. No, these are not things that taste like cardboard. These are not things that taste like cardboard. These are healthy, probiotic foods with which we can create diversity of the microbiome. Prebiotic foods as medicines. So they need to be non-digestible by the host, at least some of the components. Obviously, we can digest most of an onion, but certain aspects of it are non-digestible. And it needs to be fermentable in the digestive tract by anaerobic endogenous bacteria, in other words, probiotics. And then it must be selective in the stimulation of intestinal flora metabolism. So starches and non-starch polysaccharides are acted upon by bacterial enzymes, which create short-chain fatty acids. And short-chain fatty acids are important sources of colonic and systemic health, and they also regulate the pH. So a sick gut is either the result of or results in, it can be both, increased inflammation mediators, increased bacterial translocation, increased intestinal permeability, increased firmicute phyla, and decreased Bacteroidetes phyla, and decreased insulin sensitivity. What about a healthy gut? Well, just change the direction of all those arrows and you've got it. So it will reduce inflammation. It will reduce bacterial translocation, reduce intestinal permeability. It'll downregulate firmicutes, upregulate Bacteroidetes, and improve insulin sensitivity. And the benefits of butyrate, we keep coming back to butyrate because it's a really important thing. In fact, I mentioned it's the most important energy source for enterocytes. In fact, it's responsible for about 70% of the ATP production. It increases mucus production. It improves histone acetylation inhibition. It restores oxidative phosphorylation, which is kind of related to the first thing I said. It improves G protein coupled receptor activators. It improves oxidative stress, etc. It has impact on neurological issues. In fact, it's been shown to be beneficial for Parkinson's disease, reduces stroke damage, improves learning and memory in aged mice with Alzheimer's. Prebiotic benefits. Improves bowel function, promotes growth of healthy bacteria, improves colonic pH. It's a substrate for short-chain fatty acid production. It improves satiety. It improves bone density. It's protective against cancer. They are have these pleiotropic effects. So you can't go too far off base with prebiotic foods or supplements. So oligosaccharides are an important source of prebiotics. So there's fructose oligosaccharide and galactose oligosaccharide and all these various oligosaccharides. An oligosaccharide is actually a carbohydrate that is extracted by a biotechnology. They're not normal carbohydrates. These saccharide polymers have between 3 and 10 simple sugar links, and they work wonders for the body by improving the microbiome. They're found naturally in artichokes and chicory and onion and legumes and wheats and so on, but they're extracted from those things and made into powders and put into prebiotic supplements. So again, these prebiotic oligosaccharides, they lower the colonic pH, they discourage the growth of Clostridia, they prevent constipation and diarrhea. They have a low glycemic index. They have they lower ammonia levels. They're water soluble, and they don't bind minerals. And available in the United States, here are a few things. A lot of supplements will have many more things in it, but they won't be able to count them as fibers. So that it might say fiber, 1 gram, but then it'll say something like 5 grams of prebiotic. And that's because there are rules about what you can count as a fiber. So summary, fructose oligosaccharides, galacto-oligosaccharides are two of the most important groups of prebiotics. They have considerable health benefits. They have a very strong safety record, and they're easy to produce and store. So timeline. Well, as supplements, you want to use them until such time that the dietary changes have been made so that there's adequate prebiotic in the diet. But the dose for fructose oligosaccharide is someplace between 1 gram and 5 grams, 1 to 3 times a day. Inulin, a similar dose, 1 to 3 times a day. In other specific fibers with high solubility, like larch or modified citrus pectin, or again, going back to psyllium, can be helpful as well. And here are some references on prebiotics. Dietary fiber is broken down into the idea of soluble fiber and insoluble fiber. Soluble components are pectins, gums, insulin type inulin type fructans, and mucilages. And they can be more or less completely fermented by bacterial flora. Insoluble components are the cellulose, waxes, beta-glucans, and lignans, and they're primarily from the cell wall, and they're generally only slightly fermentable. So some examples: wheat is 90% insoluble, oats is about 50-50, as I said before, psyllium about 90% soluble. Just to visualize this a little bit, we've got selective utilization by host microorganisms. So prebiotics would be PUFAs and milk oligosaccharides and other oligosaccharides, certain phenolics and other phytochemicals, and then readily soluble fibers. The non-prebiotics would be proteins and fats, and probiotics, because they're probiotics, they're not prebiotics. And then vitamins and antibiotics certainly wouldn't be on the list, and then less fermentable fibers. So intake of fiber and whole grains is inversely related to obesity, type 2 diabetes, cardiovascular disease, and many types of cancer. And the mechanism is thought to be the development of short-chain fatty acids, results in gut hormones, which results in a change in transit time, a change in intestinal viscosity, less contact with the mucosal cells, and better estrogen excretion and better antioxidant nutrition. So in Paleolithic times, it's estimated that humans got someplace in the vicinity of 100 grams of fiber a day. That's a lot of fiber. The recommendation is about 25 to 35 grams a day. And the actual average intake is around 10. So of all the nutrients that we worry about, we don't often think about fiber, but it's very commonly deficient. So it slows the transit time in the small bowel. It increases stool bulk. It holds onto water and increases estrogen excretion. They bind minerals and other toxins, and they stimulate bacterial growth, and they're metabolized to short-chain fatty acids. So lots of important features. And here is a toolkit handout on dietary fiber. So summary: prebiotics from foods may generally be incorporated into a dietary protocol unless contraindicated. Prebiotics may often be accompanied with probiotics from foods or supplements unless contraindicated. And the contraindication is usually when you're dealing with a significant yeast overgrowth. And then prebiotic supplements should be assessed for quality and purchased from reputable commercial sources. Obviously, Prebiotic supplements are often added initially in a dysbiosis protocol, and you use them until the dietary changes are such that you don't need them anymore. So summary of feeding. Low short-chain fatty acids and or low butyrate on a stool assessment suggests deficiency in commensal flora, right? So that should result in dietary recommendations to incorporate prebiotics and probably supplements to incorporate more prebiotics. And here is the print it and put it in your folder slide. Seeding. What do we mean by that? Well, again, we've talked about the diet. Let's talk about probiotics now. So what's the definition of a probiotic? It is a non-pathogenic microorganism that, when ingested, exerts a positive influence on host health or physiology. A probiotic must be of human origin, be resistant to destruction by the gastric acid and bile, adhere to the intestinal epithelial tissue, and be able to colonize the gastrointestinal tract, if only for a short period of time. So there are many bacteria out there that are thought to have health benefits. There's a craze using soil bacteria as an example, and they may well be useful, but they aren't technically probiotics because they're not of human origin. Probiotic use, human cost of care, right? What is the social impact? So when productivity loss is included, total savings to society by use of probiotics is someplace between several $100 million and perhaps $1.5 billion per year. Antibiotic prescriptions appear to be decreased by anywhere from 1.3 to 2.6 million prescriptions of antibiotics per year. In absences from work, we may decrease absence from work by anywhere from 3.5 to nearly 4.5 million days per year. So improved disease outcomes through the use of probiotic translates into considerable cost savings for both payers and society. Okay, exploring the mutual beneficial effects of probiotic bacteria and the human host. So probiotics regulate the local and systemic immune response. There are metabolic pathways such as glycemic control and cholesterol control and amino acid control from probiotics. They support mucosal barrier, they enhance nutritional utilization, they prevent neoplastic changes, they regulate bowel motility, they regulate appetite, they regulate inflammation, and they prevent bacterial and other infection in the GI tract. So probiotics and prebiotics are very powerful interventions for managing gut health. So can we link Joan's symptoms of IBS and depression to a lack of probiotic bacteria in particular? Well, here is a meta-analysis showing a plot of these various studies. And what we see is with the exception of the confidence tails, they all these interventions reside on the side of the experimental intervention, which is the probiotics. Now, this next slide is a similar meta-analysis, but it's looking at, it's designed differently. So the intervention group is on the right side on this time. And with just 3 exceptions and a few confidence tails, we see that the use of probiotics in IBS favors the intervention of probiotics. So there's a consensus opinion. Various probiotic strains are used for diarrhea, IBS, IBD, allergy, radiation enteropathy, vaginosis and vaginitis, and even liver disease. So the problem with probiotics is, which organism, which product, for what condition, at what dose, for how long, how many side effects to be aware of, and how much does it cost? And there are lots of bacteria. So which probiotic to prescribe at what dose and for how long? And there's lots of ideas about that. You have some people saying, well, just one purified strain for just a little bit of it. And other people like me say, well, I'm on the Sagan protocol. And Carl Sagan was fond of saying billions and billions. And I believe we should use billions and billions of mixed strain probiotics. But there are others that disagree with me, sometimes vehemently. So select for their ability to survive the acid and the bile of the upper tract, and they must have some shelf life viability, and they should have quality control, right? The problem is that they're not really regulated. And there are numerous different preparations on the block, and just ask the marketing departments, theirs is the best. So a study in the UK showed that only 3 of 7 products contained the claimed culture concentrations on the label, and none of the multi-species products contained all of the labeled probiotic bacteria. And misidentification of some species was quite common. And in a US study, only 4 of 13 products were in accordance with their label claims. Typical costs are anywhere from $1 to a few dollars per day, with VSL-3 probably being the most expensive and used at a very high dose for things like inflammatory bowel disease, Culture L coming in at a close second, and then other preparations being a variable cost as well. And you may use these for several months before seeing an effect. So it takes a while. You don't just take, it's not like taking an aspirin for a headache. You need to take this for a while, and probably in conjunction with diet and lifestyle changes before you start to see effects. And if you don't make the diet and lifestyle modifications necessary to improve the microbiome, you certainly will see the positive effects discontinue after you stop the probiotic. So there are some tools you have available. Part of your membership is the Natural Medicine Database, and these other things are available either free or by prescription. What's the safety of Lactobacillus and Bifidobacterium? Well, it's used in safety and in infants without incidence of harm. It's normal in the human body. And there have been cases of infection from probiotics, but they're extremely rare, and they're really more common in the severely ill. You may remember from your primary training having chronic alcoholics with spontaneous bacterial peritonitis as an example. It's those kinds of patients that are most likely to have some kind of an infectious issue with a probiotic. So, it's really less than 1 case per million. And I think that's because the chronic alcoholics are not likely taking probiotics. So summary of seeding. Probiotics from foods may generally be incorporated into a dietary protocol unless there's a specific indication otherwise, and I can't think of one. Probiotics from foods or supplements may generally be prescribed with acute administration of antibiotics, especially S. bailardi. Now that's actually a yeast, but it's very helpful for preventing gut issues surrounding antibiotic administration. And then probiotics may be accompanied with prebiotics unless there's a contraindication such as we talked about before. Primarily that would be a heavy yeast overgrowth. And they should be assessed for quality, obviously, and you probably are going to use supplements until the diet is changed such that you don't need them anymore. So if the laboratory assessment shows a deficiency of a commensal flora, or the stool culture assessment shows an elevation of potential pathogenic bacteria, you're going to want to start with dietary recommendations and then supplements of pre and post, I keep saying pre and probiotics. And you may want to think about specific strains known to combat a specific pathogen and so on. And here is the seeding takeaway slide. And then the summary. So we certainly want to think about some probiotics in this case. We want to think about some prebiotics. But we need to remember that to date, only dietary changes or a stool transplant have been shown to actually change the microflora. Probiotics should be thought of as placeholders with only transient, although very important, effects in the gut. And then prebiotics should be thought of as fertilizers to bring up the concentrations of the actual endogenous bacteria. So I at one time was thinking of starting a series of hospitals we were going to call Stool Hospitals International for Transplantation, and I'll let you figure out the logo. And here is sort of a recap of the treatment thus far. So we've talked about this oligo-antigenic diet. We've talked about the anti-parasitic protocol. We've talked about the pancreatic enzyme addition. We've talked about adding pre and probiotics to help to start to normalize her gut. We're going to continue in just a few minutes with the rest of the 5R program.